Hi, I'm Vineet Arora. I'm an associate professor at the University of Chicago, and I'm also the director of educational initiatives at Costs of Care. Welcome to the Teaching Value in Healthcare Learning Network. Come join us to hear leaders in the field share practical and tangible advice about how to develop engaging curriculum or health system innovation to train a new generation of healthcare providers from diverse specialties and professions skilled to deliver high-value care. With national concerns about rising healthcare costs around overuse, underuse, and misuse of medical care, Costs of Care and the AVIM Foundation created the Learning Network as a space to share ideas, educational materials, and strategies in an open forum. The objectives of today are really to share an innovation and teaching value and discuss practical components of that implementation, as well as troubleshoot challenges and brainstorm how to make innovation sustainable. Today, we will share an innovation in creating value with Sachin Jain, who's the CEO of CareMore, who's going to discuss not only his philosophy at CareMore on creating value, but also the extensivist model that he's implemented there. So welcome, Sachin. How are you?
I'm terrific. Thanks so much for having me here, Vinny.
Great. I thought we could actually just start with our viewers who may not be familiar with CareMore with just a brief introduction to CareMore before we get into the extensivist model.
Great. Thanks so much. CareMore is actually celebrating its 25th anniversary. We're both a health plan and a delivery system that historically has focused on high-cost, high-need, complex seniors, but has recently, over the past few years, pivoted to also begin to serve Medicaid patients. I like to think of ourselves as big game hunters. We are trying to solve some of the biggest problems in American healthcare. Namely, how do you better manage the care of some of our most complex patients? I think we came to prominence about 5 years ago because as there's an increasing focus on cost and quality, CareMore's model, which really focuses on continuity of care across inpatient, post-acute, and post-discharge follow-up settings, as well as exquisite management of chronic diseases, was found to result in lower costs and lower utilization. And so we're really, quite proud of what we're doing and really excited to share our work with you here today.
No, that's great. And certainly everything you're talking about is very timely given our current political climate as well as our healthcare challenges facing us. So I would be really fascinated to learn a little bit more about the extensivist model and specifically how you choose patients that are appropriate for that model versus a more traditional model of care.
Yeah, so extensivists are actually hospitalist physicians who practice an adjunct with primary care. The patient will first meet an extensivist when they're admitted to the hospital. And they'll see the patient in the hospital, but I think what's exciting about the extensivist model is that our patients will then be followed, in the SNF setting by the same extensivist, and also will be followed in post-discharge clinic. And so there's, the typical discontinuities that exist in American medicine today, meaning you have one primary care doctor who sees the patient as an outpatient, another physician who sees the patient as an inpatient, another SNF physician who sees them in post-discharge care, and then you're back to that primary care physician for post-discharge follow-up. Is really replaced with a single physician who actually sees the patient, continuously across an acute episode of care. Now, I think some patients who are particularly ill will continue to be followed over a longer period of time by extensivists who will co-manage the patient with primary care physicians. And we usually, choose those patients by looking at, patients who've been readmitted frequently, or patients who are particularly high risk for hospitalizations because their illness or their condition is deteriorating.
Great. One other question I had, just thinking about sort of the transitions involved with an extensivist model, it sounds like there is actually a time when a patient who was treated by an extensivist actually will get healthy enough to go back to the traditional model of care. Can you talk about who determines that and how that actually ends up happening? And are there patients that come back in and out of extensivist care then?
Yeah, so I think, the extensive, I like to think that the, best big data machine is the human brain. And I think that our extensivists who are very skilled clinicians use all of their clinical judgment and insight to determine when a patient is appropriate for discharge from the extensivist care, and will ultimately reassume care sometimes if a patient happens to be readmitted to the hospital. They'll get back involved in their care. So a lot of it is really relying on that frontline clinical judgment. There's a lot of talk these days about predictive analytics and risk models, but I tend to think that the clinical judgment of clinicians oftentimes supersedes or replicates what some of those big data algorithms enable us to do. I think one of the key pieces of our model is that we have clinicians who touch our patients, and so we're able to really identify who might need that extra human touch just by the eyeball test, which is really looking at our patients and understanding who might be at risk and who isn't. I think another kind of key piece of our model is all the adjuncts, all the additional support that we provide patients through our model of care. So we have case managers who are really looking at whether our patients have everything that they need to stay out of the hospital. We've got intensive chronic disease management programs for the most common chronic diseases of the frail elder population. And so even when a patient isn't necessarily in an extensivist care, they may be touching other parts of our system. They may be touching our case managers. They may be touching our nurse practitioners who are delivering some of our chronic disease management programs. And so at any point along that continuum, there's an opportunity for any one of those folks to raise their hand and say, I think this patient is becoming particularly high risk and we'd like to move them back into the care of an extensivist. So I think that there's really opportunities all along the spectrum to readmit a patient to an extensivist care. One of the points that I think is really important for this audience is the fact that what we're really focused on is reducing hospital days. One of the areas of greatest waste from my perspective is inpatient utilization. And there's lots of care that can be provided either as an outpatient or in a SNF setting. And so we're always trying to step down our patients from an acute setting to a post-acute setting. And we think that there's tons of value to be created in the healthcare system by doing that. And one of the things that the extensivist model allows you to do is confidently do that, because you know that you're not handing off the care of this patient to a stranger, that you'll be seeing the patient in those other settings. And so it gives you the confidence to be able to kind of move them from an acute setting where the average hospital day for us is around $3,000 per day to a post-acute setting where we might be spending $300 a day. And so if you think about the cost arbitrage there and the opportunity to really create value for the healthcare system, the extensivist model enables us to really push patients along that acute continuum more confidently, because they are going to be the eyes and ears, making sure that that patient is safely cared for in those other settings. And I know from my experiences practicing in other settings that you don't always have that confidence, because you are discharging the care to a stranger, and the only mode of actually communicating what happened in that inpatient setting is a discharge summary that may or may not show up with the patient. And so the fact that it really is the same person and the same care team that's taking care of the patient across settings, I think really changes the experience for the patient, and frankly, the experience and confidence for the provider who's taking care of that patient.
Yeah, no, that makes great sense. And it's good to know that that clinician judgment is still sort of the center and heart of all of this, particularly as we think about, who is seeing these patients up close. I was also curious, one of the things that we think a lot about is, how do you prevent burnout and promote resilience? And I'm just thinking about these physician extensivists who are having these panels of patients but are very acutely ill, and also having to follow them in and out of the hospital, and having an incentive to get them to post-acute care. But can you talk about any special programs or things that you've needed to implement, or things you've noticed that are important for this type of workforce to work?
Yeah, that's a great question. And I think that we at CareMore think about this all the time, because you can't actually take care of our sickest patients in the healthcare system unless you're feeling balanced and you're feeling well supported. So a couple of kind of key differences between the extensivist model and other types of models of care. So your traditional hospitalist model has you seeing patients 7 on, 7 off, 12-hour days, seeing 20 to 30 patients a day. I mean, that's what it is to be a hospitalist in American medicine today. Our extensivists will see, on average, 5 to 7 patients in a morning, and then they'll have post-discharge or sniff rounds in the afternoon. And they work typically from 8 to 5 days a week. And so it's a much more sustainable lifestyle because you aren't doing this, high intensity, cortisol intensive, 7 on, 7 off, 12-hour days. And I think that, it appeals to people, particularly to, experienced hospitalists who have burnt themselves out doing the 7 on, 7 off, because, an 8 to 5 model ends up being, I think, much more tenable. And we really focus on high quality patient interactions. So, when we say you have 5 to 7 patients on any given morning, what that enables you to do is do all the little things that we know are elements of quality care. You're able to, consult the specialist yourself and have those conversations. You're able to have those conversations with primary care doctors. There's enough time to actually engage family. And so our clinicians, when our censuses are managed well, don't feel burnt out because they actually have the time in the day to do the things that you need to do. Now, where burnout does become a problem is, when we have geographic spread. And so if your SNF is far away from the hospital where you're practicing and far away from your clinic, a lot of our clinicians do complain that they are, driving long distances, and the burnout really arises there. And so we're on a mission right now to really try to consolidate geographies, to narrow our networks of hospitals and SNFs and clinics so that rather than having to drive a distance to go to a clinic, you're able to walk across the street and see the patients and post-discharge follow-up in that way. And I think these little things actually make a really, really big difference. The details that really matter to clinicians. Do your IT systems work? Does case management really reliably execute your care plans? Is there a pharmacy department that is able to help with MedRec? I mean, those little things make a huge difference to clinicians in the front lines. And it's become really trite and passe to talk about joy of work. Every system talks about it. Every system gives lip service to it. Every conference you go to talks about it. It's something that, because we're a physician-led organization, it's something that is at the center of everything that we do. And we're not perfect. I don't want to create any kind of wrong impression about that. But we are constantly striving to make, work better for the clinicians who work within our system.
Yeah, no, that sounds really great, and it's great to hear that that this job sounds actually very sustainable compared to traditional hospitalist care with the 8 to 5, and and also and promoting some of those substantive patient interactions that actually would yield joy.
Yeah, I mean, a lot of us went to medical school writing personal statements that talk about continuity of care and relationships, and what we've really seen over the last 20 years in American medicine is the atomization of American healthcare. Outpatient is separated from inpatient. SNF care is separated from both of those. And what I think you have is a lot of transactions as opposed to relationships. And I think we have to move away from transactions. I think a transaction-based view is fine for many other sectors of our economy, but I think in healthcare, we need to hold on tight to the notion of continuous relationships, and our doctors know our patients, and I think that that's something that they take a lot of pride in, and it's something that is at the foundation of what we do, and is not something that we're willing to negotiate on or change. Whereas I think a lot of systems have been a little bit penny wise, pound foolish in trying to really subsegment things to the point where you actually lose the essence of them.
Yeah. I know that, and that leads me to my next question, because I know that turnover is always the nemesis of any healthcare organization and any organization really, and certainly is something that I know that as hospitalists we deal with a lot. Have you seen a lot of turnover in your extensivists, or is this something that I think people are signing up to do as a career, it sounds like?
Yeah, I think in the first year, you get people who are not sure if this is the right model for them. Because it is so different from everything else that they practice. I mean, I think a lot of times senior residents in internal medicine have to declare, do I like clinic or do I like the hospital? And the two of them come with very different lifestyles, very different pay scales. And so I think, our model is a hybrid of those two things, and you have to like both. And, we really recruit for people who love medicine and who love taking care of patients and who love continuity, but also still like the hospital. And so I think in the first year, some people will self-select and realize that it's not really for them. But I think the folks who end up staying with us beyond that first year really love it, and couldn't imagine themselves doing anything else, because they, uniquely are able to do all of it. And so, I think another piece of it, frankly, is making sure that you pay people well. And it's not something that we talk a lot about in healthcare. It's almost a taboo to talk about, being, what you're paid. But we actually realize that the value of a clinician goes up over time. Their effectiveness and actually operating within our model, I think, changes over time. And so we do put a huge premium on tenure, and connecting tenure to outcomes. And so our clinicians are able to earn very substantial bonuses over time, up to 65% of their base salary. That's really tied to performance after they've been with us for a while, because we really do want to value senior clinicians within our system. And so I think, again, it goes back to being a physician-led, physician-driven organization. I think it allows us to focus on what's really important to doctors. And again, we're not perfect. There's still things that we're trying to tweak and make better. But we really try to be appealing to folks who want to provide, high quality care to some of our most complex, patients in the workforce.
No, that's great. One thing I know that people have asked about the extensivist model that I would love to get your opinion on is, we're right now sort of in this 1 foot in, 1 foot out with, value and alternative quality contracts and sort of shared savings programs. And so do you see the growth of extensivists, being facilitated by the move to value? And if so, can you march out? Would it be possible to do it if you didn't have a payment system set up to reward value?
Yeah, so I think that we have to stop being schizophrenic about this. I think we have to be, fully in the boat of accepting that, capitation is not risk; it's really freedom. It enables you to do the things that you need to do to really effectively take care of patients. And we're at CareMore, because we're both the plan and the delivery system. We're fully at risk for every healthcare dollar that is spent, for the care of our patients. And what it enables us to do is to bring common sense back into the design of the healthcare system. If you were, really designing a healthcare system from scratch, you would never have a different set of clinicians taking care of patients across all these settings, generating all these handoffs, generating all these errors, generating, medication reconciliation problems. You would really want, continuity in these acute episodes. And so, and what it does is going back to what I said before, is it creates the opportunity to utilize lower cost settings. And, if you were able to lower the length of stay, which from 5.3, which is the Medicare average, to 3.7, which is what we do, you're able to generate $4,500 of savings on every hospital admission. That generates real value. And in the world of Medicare Advantage, where you have to actually plow, savings back into benefits for patients, it enables you to actually generate real benefits for patients and increase their overall value of their care. And that's, I think, been the key to the CareMore model. We don't live in three different worlds. We live in a full risk world where we take care of our patients. We provide, inpatient and outpatient services to our patients. And I think it enables us to redesign the system. Now, if you had many masters and many different payment models, you're never able to really fully redesign the system. And I think that makes what we do special. And we've invested a lot of resources as a private company in actually training and physician education, because we find that we actually have to unteach people bad behaviors when they come to CareMore, and unteach them the kind of games that people play in the fee-for-service world, and get them thinking about what care can and should look like in a world in which incentives between the system, the physician, and the patients are truly aligned. And ultimately, the savings that we generate result in better care and better benefits for our patients. We're able to offer them more as a Medicare Advantage plan. And I think that that's a dynamic that a lot of people don't frankly have the benefit of, and one of the reasons why I'm really excited about the work that we're doing here at CareMore.
Yeah, no, it sounds really exciting. And actually, that sort of leads to my next question. You mentioned training and sort of also, unlearning. We're hearing a lot about unlearning and the need to unlearn. So what would your advice be to people who are actually producing our graduates of our residency programs and our medical schools? We have a lot of educators who do watch to learn more about what should they be preparing the workforce of the future to do. So what are some of those things that you would advise people learn about that would make them better prepared for working at CareMore?
Yeah, no, thanks. So one of the things I'm really worried about in academic medicine, as somebody who's a recovering academic medicine person, is the fact that as people progress in their careers, they do less and less clinical work. And I think it sends an implicit message to new trainees that good over the course of your career looks like less and less clinical work. And I just worry sometimes. I wake up worrying sometimes, who's going to take care of all these patients if our best physicians are constantly looking for their time to be bought down over time. And I think that we need to change the value system. We need to re-inspire people about the value of clinical practice, the value of continuous clinical practice. Everyone in our company, from the president and CEO down, who's a physician, continues to see patients. We don't have any physicians who are not seeing patients. Contrast that with a lot of organizations where a lot of people are working towards getting to a place where they don't have to see a lot of patients. And so, our value system at CareMore is that even if you're a physician leader, you're still seeing a significant load of patients because you're not able to change healthcare without actually practicing within it. And I think that you become an inauthentic leader over time when you are trying to lead something that you don't have to practice within. And so I think that there's a real need for physician educators to get back to seeing patients and kind of restoring the value and virtue in actually seeing patients. We've commoditized healthcare. The way we treat hospitalists as if they're replaceable parts. We treat specialists like they're replaceable parts. And a lot of what we do in academic medicine is we play pickup basketball. Whoever's on call is seeing our patients. And we've I think de-emphasized the value of clinical excellence. And I think we need to really take a hard look at what clinical excellence looks like. What does it mean to reward clinical excellence? What does it mean to promote clinical excellence? And I think that unfortunately somewhere along the lines, that's getting lost. And I would put it back to you, Vinny, as a medical educator. How do you think about that? How do you think about really rewarding clinical excellence in a world where everyone expects to get an A, and where everyone is treated more or less like a replaceable part, like a hospitalist is a hospitalist is a hospitalist. That's not how our patients are thinking about their care. They really want to see only the best and brightest, and that's where we've moved a lot in the last couple of years at CareMore away from thinking about kind of anyone with an internal medicine board certification is qualified for our jobs, to really looking at the alignment between the values in terms of what we value as an organization and what clinicians individually value, and making sure that there's a real fit there.
So I know that I could talk to you probably for another hour, and I'm thinking that a lot of people have a lot of other interesting questions. So I think this will actually generate a lot of interest in your work, Sachin. But before we end, I wanted to see if you had anything else that you wanted to touch upon for our viewers.
Yeah, I just want to invite your viewers to reach out to us. CareMore is always on the lookout for great physician talent. If you're a physician, we're always on the lookout for great administrative talent. We're now in 7 states. So we're in Arizona, Nevada, California, both Southern and Northern California, Memphis, Tennessee, Des Moines, Atlanta, and Richmond, Virginia. And so we're always on the lookout for great people. So I really invite folks to reach out to me. My email address is just my first name, Sachin.Jain, my last name, at CareMore.com. Again, Sachin.Jain at CareMore.com. And we'd really love to hear from folks who are interested in either learning more, interested in partnering with CareMore, bringing the CareMore model to your organization, or looking to potentially join us. We've got a tremendous partnership that's in its 3rd year with the Emory Health System, where we are the value-based healthcare transformation partner for Emory. and take care of over 6,000 Medicare Advantage patients, within the CareMore model of care at Emory. And so we're always looking for interesting and innovative partners who are interested in doing the same thing that we are, which is really improving the value of healthcare, improving quality and reducing costs for complex patients. So thank you very much.
Okay. Well, I want to thank Sachin Jain for joining us here on the Teaching Value in Healthcare Learning Network that's brought to you by Cost of Care and ABIM Foundation. And I look forward to talking with you further, Sachin, and hearing about follow-up on some of these exciting innovations in the future. Thank you.
Thanks so much, Vineet. Really appreciate it.
Thanks.